Okay, a pleasant evening to one and all. I feel honored to share this special program which has been started by current ISVR executive, that is IR Masterclass with practice to perfect, which will be conducted every fortnight. And I take this opportunity to thank all our ISVR executive for this wonderful initiative. Myself, Dr. Chandrasekhar, I'm a Joint Secretary ISVR and will be moderating all the sessions of Masterclass henceforth. I hope our proposed program will immensely help all the IR practitioners, residents, and fellows. And we will cover all the topics of intervention radiology, right from basic to advanced topics, from puncture to advanced latest techniques. And all the videos will subsequently uploaded in ISVR site. And each class will be taken by the renowned IR practitioners and renowned names, faculty from all across the countries. And without wasting time, let me introduce our first IR master, Dr. Sanjeev Kumar. He is currently working as additional professor in the Department of Cardiovascular Radiology and Endovascular Interventions at All India Institute of Medical Sciences, New Delhi. And his main areas of interest are vascular intervention radiology with special interest in aortic interventions. He is not only a great academician, but also a very good teacher and has a immense passion for teaching IR. And he has over more than 200 publications in national and international journals and delivered numerous lectures across the globe and conducted many workshops and won many awards in national and international arena. And Dr. Sanjeev will be taking the first the IR masterclass, and it is the most basic topic of IR, that is vascular access, without which our basic opening gate of our intervention radiology is gaining the access. And he will talk on the mainly arterial access, not the venous one, and he will speak about various techniques, types, and associated complications. And and also he will try to cover the most advanced any techniques as well. Dr. Sanjeev, please.
Thank you, Dr. Chandrasekhar sir, for a kind introduction, and I thank all the executive members of the ISVR for inviting me here to deliver this talk. I'm sharing my screen first. I hope my screen is shared and the slide is visible.
Yes, yes. Dr. Sanjeev, please carry on.
So moving further without wasting any time, as Dr. Chandrasekhar has already told, that we will be discussing about the basic of vascular accesses, the different technique, the complications which happen with them, and how to prevent them, and also how to manage them. So let's start with this picture. When you see this picture, what comes to your mind? Here, if you see this patient, the patient looked terrified with a lot of stick on his body because of the multiple failed attempt by the staff nurse to get the vascular access in this patient, which was very important to deliver the intended therapy. While at the other end, you will see that this is a picture of a groin where a vascular access was taken. An endovascular procedure was done very successfully, brilliantly. However, at the end of the procedure, you can see this kind of groin, lot of hematoma, edema, and swelling. And believe me, when you see this kind of picture at the end of a successful procedure, how good soever you have done your procedure, the procedure will always be called as a bad procedure. So what I mean to say is that proficiency in different vascular access is key for the safe and successful outcome of the endovascular procedures, because we know that the no access means no intervention. Before moving on to a particular access, there are few points which I would like to highlight once again. Take history, especially related to presence of any peripheral artery disease once the patient is on the table. Ask for the history, whether patient had underwent any aortobifemoral surgery or patient had been done any iliac stenting in the vicinity of your access, or was there any use of closure device at the intended puncture site before you are taking this puncture, because all this knowledge can change your access technique as well as access strategy. Checking the pulse at the site of puncture is not only important for the puncture, but also taking the distal pulses are equally important, because that will play a major role in the aftercare when you remove your sheath for hemostasis. Among the physical examination, one thing I would always like to highlight, always look at the groin, look at whether there is any local infection or not, because you never want to introduce a superficial skin infection inside the blood and make it systemic. It's also important that you determine whether the patient can lie in supine for a prolonged period of time, because you don't require a patient supine only during the procedure, but also in the post-care. So if the patient had the issue of back pain or maybe congestive heart failure, he will not be able to lie down for a long, and hence your puncture strategy may change in this group of patients. Once you have identified the site of the puncture, clean it, drape it, the area of interest very nicely, and do it in a surgical manner the surgical guys used to do it. As far as the hardware is concerned, you should be ready with all the hardwares, the puncture needles, the introducer kits, the sheath, vascular sheath, wire and catheters, which are compatible with the given access system. So there are different kind of puncture needles, sizes and length, which are color coded. The size of the puncture needle is decided by the kind of the introducer sheath, whether we want to introduce a 035 system, whether we want to use a 025 or a 014 system. Similarly, the length of the puncture needle is decided by the depth of the vessel from the intended skin side. Normally, there are two kinds of needles. For the 035 system, normally 18 gauge needle is used. And they are roughly divided into two parts. As you can see in this superior picture, the one needle with plastic outer cannula and metal stellate inside, which has got a short bevel. The stylet which is there inside this plastic cannula has a short bevel, and hence this kind of needles are less traumatic. And they are also preferred over the metallic needles. They come with hydrophilic wires. Since if you are typically assessing a lesion which is or an access which is close to a stenosis, or there is an upstream tortuous vessel, you should prefer this hydrophilic wire for navigation in those situations. The other kind of needle is the metallic needle, which has a long bevel, as you can see in this example of this picture. And it is typically preferred in patients who are obese or maybe had some scarring in the groin, because it may be difficult to introduce the plastic cannula needle in those patients. These needles typically come with this non-hydrophilic guide wire. One thing which is very important whenever you are using this needle with a long bevel and metallic cannula, you should remember that because of the long bevel of this needle, sometimes the needle is partially inside the vessel and partially in the vessel wall. And still you will have a good pulsatile return. And if you introduce the wire inadvertently, it will cause a dissection just like this. So be aware of this long bevel needle, and never use a hydrophilic wire with this needle, because they can strip the coating of the hydrophilic wire and can cause inadvertent complication in many of this situation. Just like the needles, we also have the vascular sheath, which is the backbone for a steady vascular access. And they also come in different sizes, length, wire compatibility. And depending upon, again, the area of interest, the vascular intervention you want, you can choose different kind of vascular sheath. And they are also color coded as the needles are color coded. There are the two important basic components. The one is the dilator and the another is the sheath hub proper, which has a side port with a three-way stopcock, which is used for flushing, delivering contrast, or giving some drugs in this way. This hub has got a hemostatic wall, which doesn't allow retrograde flow from the vessel, but allows you to pass the wire and catheter through this hub. So know your vascular sheath beforehand, prepare it nicely before taking any puncture of the vessels. Also for special accesses, like for example, if you are doing a superficial small vessel access, we typically used a micro puncture set, which again come with a smaller size needle and a dilator as well as sheath, which is smaller in length as compared to an adult needle. And you should learn all this before taking a puncture in a given patient. One thing again, I would like to re-emphasize that local anesthesia, giving local anesthesia is an art. And if you do your art carefully, believe me, the patient will be comfortable during the procedure. And once the patient is comfortable, you will be comfortable and you have less complications. If you don't give it optimally, there are chances of patient discomfort, and patient discomfort means that you are in discomfort. Typically, we give lignocaine 1 to 2% in concentration with or without epinephrine. Addition of epinephrine helps in prolonging the duration of the action, and you should remember the dosage which is typically delivered in any patient based on the absolute weight, which is 5 to 7 milligram per kilogram of the body weight if you are using epinephrine. But if you are using without epinephrine, the doses will be slightly lower. Typically, in an adult patient, if you are taking a femoral puncture and you are using a 2% lignocaine hydrochloride, 10 to 20 ml of lignocaine is sufficient enough for this patient. It not only helps in relieving the pain in the patient, but it also helps in elevation and fixation of the vessel, because this vessel often at times tend to slip. It also had got a local spasmolytic effect, which will prevent the vessel into going spasm. You should always first give a dermal injection with a 25 gauge needle, and once you do that, you take a larger size needle with a 22 gauge, go medial and lateral to the artery, first aspirate, check whether there is no blood coming, and once the blood is not coming, inject it and come more superficial. One thing again I would like to highlight is that if you are dealing or giving a patient with a cardiovascular compromise, suppose a bleeding aneurysm, you want to do angiography, you want to give a local anesthesia in those patients, don't use the epinephrine mixture in those, because we know that a inadvertent injection of epinephrine in the vessel can cause tachycardia and hypotension and can further accentuate the given hemodynamic abnormality in a given patient. This is a small, this slide actually depicts about the different puncture technique. And this first row show you the classical Sandligner technique, where what you do is that you place your needle 1 to 2 centimeter below the intended vascular site at an angle of 45 degree. And then you traverse the needle along the vessel through and through. Then you start withdrawing the needle. And when there is a good pulsatile flow, you introduce the wire, and then you press the wire with one hand, remove the needle and take the appropriate size introducer sheath and place the introducer sheath inside the vessel in a rotatory manner. Another modification of this technique is the single wall puncture technique, where you advance the needle in the same manner as you do in the double wall puncture technique. However, you go slow, and once there is a slight return, as you can see in this picture, you further go a millimeter or bit so that you can ensure that the tip of the needle is inside the lumen. Once you are inside the needle, you will see a brisk pulsatile flow, and then you can introduce your wire in the same way as you do in the double puncture technique. This single wall puncture technique is especially recommended if you are doing any kind of access or doing a procedure where the risk of bleeding is high. As for example, if you are planning to do a thrombolytic procedure, you should always try to achieve this single wall puncture as compared to a double wall, where the risk of ooze or hematoma will be higher in those situations. So try to learn each of this technique, and you can adapt any one of these according to the situation. Moving to the accesses proper, in today's class, we will discuss about the arterial access. We will leave the venous or intraosseous access maybe to some other class. And among the arterial access, I will discuss about the lower extremity access as well as the upper extremities, starting from the femoral and going down further each one by one. So when we talk about the retrograde femoral access, it is the most common arterial access for decades for the intervention radiologists and often called as a prime time for the IR people. So why this common femoral artery is chosen for the puncture and getting access? Because it is relatively larger in size as compared to other vessels like a popliteal, radial, or brachial. It allows for the ease of cannulation as compared to the other vessel again. And the most important thing is that there is a bone underneath, that is the femoral head, which allows for a good hemostasis after you remove your sheath. So before coming to how to puncture the common femoral artery, let's try to understand the anatomy of the common femoral artery. And as you can see on this schematic representation, the external iliac artery, after giving the inferior epigastric branch, passes underneath the inguinal ligament, and it becomes the common femoral artery. And this is the artery we want to puncture. This artery runs a medial 1/3 course over the femoral head and usually bifurcate at the inferior end of the femoral head into profunda and the superficial femoral artery. So what are the different techniques by which we can actually puncture common femoral artery, which is the ideal puncture site for a femoral retrograde femoral axis? So there are various techniques which are described to puncture for common femoral artery: inguinal crease as a reference standard, bony landmark, point of maximum pulsation, fluoroscopic landmarks, ultrasound guidance, or a combination of this, and we will see each one by one. So normally or conventionally, inguinal crease was taken as a reference standard for inguinal ligament. However, if you see at this line, you can see that the distance between the inguinal crease and inguinal ligament can vary as high as 0 to 11 centimeter with a mean of 6.5 centimeter. So if we take inguinal ligament as a reference standard for inguinal crease as a reference standard for inguinal ligament, we may erroneously result in a low puncture in majority of the patient, because bifurcation of the common femoral artery is above the inguinal crease in up to 2/3 or 3/4 of the patient. So of course, this inguinal crease should never be used as a reference standard for puncture of common femoral artery in any of this patient. What about the maximum femoral pulse? So as you can look at this diagram, that when the common femoral artery passes over the femoral head, it becomes the most superficial, and it is the point where you can get the maximum femoral pulse. However, again, it is a subjective finding, though it is more reliable than using an inguinal crease as a reference standard to puncture the CFA, and may become troublesome in obese patient or patient with a hypotension, patient with a poor pulse. It may not, you may not be able to palpate or feel the maximum femoral pulse so nicely. What about the bony landmarks? So you can see on this picture that this is the anterior superior iliac spine and this is the symphysis pubis. And when you draw an imaginary line from the anterior superior iliac spine to the symphysis pubis, it represents the inguinal ligament. And from the anatomy slide, we know that this common femoral artery passes beneath this inguinal ligament at the midpoint, and we can puncture 2 to 2.5 centimeter below this midpoint of the imaginary line. This could suffice in majority of the situation, but again, in the patient who had got obesity or prior hematoma or a scarring, this anatomical bony landmark may be slightly altered. What about fluoroscopy? Is it superior to other methods? So we know by now that the common femoral artery bifurcates below the mid portion of the femoral head in more than 98.5% of patients, and it runs along the medial third of the femoral head. So if you puncture the artery at the junction of the medial 1/3 and upper 1/3 at this point, we are likely to be 99% accurate in puncturing common femoral artery. And also it is good for patients who are morbidly obese, or also patients who had a lack of palpable femoral pulses. But the point to remember is that your artery should not direct in this way, because it can result in inadvertent perforation or a penetration of the vessel, and it can also go in the adjacent soft tissue. You should direct always your needle in parallel to the course of the iliac and the femoral vessels. A combination of these methods, like anatomical, that is taking a landmark, bony landmark, anterior superior iliac spine and symphysis pubis, drawing an imaginary line, coming 2 to 3 centimeter below this line in the middle point, palpating the maximum pulse, and then putting your maybe a trocar or a artery forceps to look at on fluoroscopy, that whether you are at the right position or not may be ideal for the beginners, because this, if you do combination of this, more than 99% of the situation, you will be hitting the artery at a right point. What about ultrasound, role of ultrasound guidance? So we know that since we are visualizing the needle as well as artery in the real time, it will reduce the number of attempts, especially in patients who are obese or patients who have weak or absent pulses. But one area where I would like to specify is that patient who have got a high CFA bifurcation, and in 1 to 2% of the patient could have a high CFA bifurcation, and in those cases, ultrasound is really handy in knowing that which branch, where you are actually puncturing the artery. Also, it decreases the risk of inadvertent venous puncture and reduces the incidence of fistula, AV fistula, and other vascular complications. So how we typically do in ultrasound is that we put our probe longitudinal like this at the region of the common femoral artery. And you can see that this is the common femoral artery. There is some plaque at the region of the bifurcation. This is the profunda and this is the SFA. And then you put your needle like this at an angle of 45 degrees, and then you traverse your needle. By using ultrasound, you can even avoid puncturing these or disrupting these plaques, which could be fatal, which could be dangerous in many times. If you disrupt it, it can cause embolization. So you can do it in ultrasound guided, put C or echogenic tip of the needle inside the vessel, and once a good return comes, you introduce your guide wire. So a combination of all this is very handy in different situations, and you should follow. As a beginner, I would advise everyone to follow the combination of these methods. So just to recapitulate, this is how you give a local anesthesia 1 to 2 centimeters below in the same manner as you will introduce your needle. Then you puncture the skin side 1 to 2 centimeters below the intended vascular puncture site at an angle of 45 degrees, traverse the needle, and once there is a good return, pulsatile flow, you press this, introduce the guide wire, press this point, remove the needle, and then introduce the introducer sheath through a rotation. And if there is any difficulty or resistance, always try to give a small nick at the skin incision site for a smooth passage of the. Adequately hypertonize your sheath, and always pass your guide wire under fluoroscopy, because if you don't pass your guide wire under fluoroscopy, it can again result in inadvertent complications. Moving from the common femoral retrograde approach, that was called as retrograde because we introduced the needle against the direction of the flow. Moving to antegrade femoral, where you actually puncture in the direction of the flow, that is in the femoral artery. It has got obvious advantage that you will have a shorter working distance if you are revascularizing a ipsilateral limb. It will provide you better pushability or torqueability of your wire and devices. And also in situation where there is a tight aortic bifurcation, you will avoid coming from the contralateral approach. However, the main problem when you take antegrade femoral approach is in patients who are obese. So what happens is that because of the obesity, it's difficult to get a skin access 2 to 3 centimeters above the intended puncture site. And in those situations, it's always advisable to put a strap on the abdomen and pull the abdomen on the contralateral side so that you will get an easier access to cannulate the common femoral artery. What you have to remember is that whether you are doing an antegrade femoral or a retrograde femoral approach, the site of vascular entry is same. That is the common femoral artery site. Only the skin puncture site changes when you come from antegrade femoral. Now you will be most likely puncturing 2 to 3 centimeters above this point. So it will be the skin puncture will be above the inguinal ligament. And the important point again here is to that you should direct your needle again in the direction of the superficial femoral artery, because if you direct your needle in a mediolateral manner, the wire will always go into the profunda femoris artery. So always place your needle slightly parallel along the track of the common femoral and SFA. There will be situation where despite of multiple attempts, the wire will not go in the SFA. And in those situations, what you can do is that you exchange that wire with your oven 4 wire, place that wire in the profunda femoris, advance your seat into slightly in the profunda femoris, take then use another wire, advance that wire, and then try to reposition the second wire into the septophemoral artery. We have also devices which are called as redirecting devices, which have got a side hole where you can actually introduce a wire which will go into the superficial femoral artery. However, these are rarely required if the direction of your needle is right. Sometimes you will have a situation like this. So this is an example of a patient who had got a common iliac artery occlusion on the right side with ipsilateral occlusion of the superficial femoral artery. So you can have various access techniques to revascularize this portion as well as this portion. You can come from contralateral retrograde femoral approach. However, contralateral retrograde femoral approach, when you try, it will be difficult to place your stent in this location from this side. You can come from an upper extremity approach. However, it may be limited if you want to intervene in a distal lesion like a superficial femoral artery. And one of the approach which has been described is first you take a retrograde femoral access try to recanalize this one. And once you are done with recanalization of this territory, you can convert the same retrograde femoral axis into antegrade femoral axis, and then you can recanalize this vessel as well. So what I mean is that in those kind of situation, how you can convert is that you can take a reverse curve catheter once you are done finishing the recanalization of the proximal vessel. With this recurve catheter or a reverse curve catheter like a sauce amini, you can introduce a wire into the superficial femoral artery, and once the wire goes into superficial femoral artery, you take out the sheath as well as the catheter together outside, and once it come outside, you can reverse the direction of the sheath in the antegrade manner in the superficial femoral artery. The only trick which is important to remember here is that normally in a conventional retrograde femoral puncture, we keep our needle at a 45-degree angle. But if you have already planned that you will convert your retrograde axis into an antegrade axis, never take that angle 45 degrees. Try to go much vertical, maybe an angle of 80 to 90 degrees. Because if you try to convert a 45-degree angle retrograde axis into an antegrade axis, and if you put your sheath, the track will be much tortuous and there will be bending in the sheath, and you may not be able to perform your procedure. So be more vertical in those situations where you have already intended to go from retrograde to antegrade femoral. You can also have a situation like this, where you could have a occlusion of the right common iliac artery, as well as the long segment occlusion of the superficial femoral artery starting from the ostia and going till the adductor canal. Again, various strategy of accesses could be chosen in this patient, and one of the strategy is taking actually the popliteal axis. So the popliteal axis was first described by the Tonneson in 1988, and it was classically described in a retrograde or a prone position. As you can see in this example, the patient was placed prone, and either using a ultrasound guidance or maybe a roadmap or a fluoroscopy technique, you can puncture the popliteal artery just above the knee joint. But what was the problem of a retrograde prone popliteal artery puncture was that you exclude out the possibility of doing intervention with a combined approach from above as well as below, because the patient is already prone. Now you cannot use a femoral or a brachial approach to do a combined procedure. So you are not dedicated yourself to do the procedure from the popliteal approach, and in those situations, the popliteal diameter should be at least 4 mm in size to do intervention of the iliac or the femoral territory. Also, it becomes difficult to do this kind of procedure in obese patient and patient who are COPD. They are not able to lie down long in the prone position. So this prone popliteal artery puncture technique has not gained popularity, though it has been described 2 or 3 decades back. And it also results in access site complications, especially AV fistula. Because when you do this puncture in a prone position, the artery and vein lies anteroposterior and often result in inadvent arteriovenous fistula in this situation. So can we do anything about this? Yes, certainly, yes. To overcome this, a supine retrograde popliteal approach was developed to overcome the problems which were associated with prone axis. And what you typically do is that once your procedure fails from a retrograde contralateral femoral or antegrade femoral axis, you gently flex the knee in the 120-degree rotation, as you can see in this diagram, and you try to slightly medially rotate. So once you do this medial rotation, the artery and vein get slightly separated, and you then puncture in a cordocranial direction. So this puncture could be done in different ways. We can use a fluoroscopy if the vessel is heavily calcified. We can use a roadmap technique by giving an injection from above, either antegrade femoral or a retrograde contralateral femoral. However, the best way to do is that ultrasound guided puncture. As you can see in these images, when the patient is prone, the artery and vein is lying totally anteroposterior, and it's difficult to puncture sometimes in this manner. But when you rotate the limb medially, you can see that this artery and vein get separated. And you can puncture then the artery more safely as compared to a prone position. And it's also important to remember that you should puncture the artery caudal to semimembranous muscle. Because if you puncture more prone to or more proximal, you will have a longer track and a long muscle fiber to traverse, which is not advisable because then it will create problems with the compression and everything else. The ideal point to puncture in this is either at the level of the knee joint or slightly above. When we use the popliteal puncture, or for that matter, any vessels which are smaller in size, we typically preferred a micro puncture needle, which is a 21 gauge needle as opposed to 18 gauge needle, which comes with the, which we use for the conventional femoral puncture. It is less traumatic, and it also we can have allow for a sheath or no sheath approach depending upon whether we want to do the procedure from below or above. Most likely you can cross the lesion from below, snare the wire from above, and you can do the procedure from above. So a no sheathless approach can also be adopted if we are using a supine rotated popliteal artery access. Moving to pedal access, which is often a time required when there is a failed antegrade recanalization of the femoral, popliteal, or the tibial vessels. And it is also postulated that if there is a chronic total occlusion, the proximal part of the cap is actually more resistant and firm, which often allows the wire to go in subintimal space if we are coming from above. However, if we are going from below, the lower part of the plaque is more soft, and it allows easy traversal of the plaque and recanalization of even the chronic total occlusions. What is more important to remember is that when we are planning a pedal access, don't give too much of anesthesia because the vessel is very superficial, very small in size. Maybe a 1 or 2 ml of local anesthesia is good enough, because if you give too much of anesthesia, it can cause vasoconstriction of the vessel and issues related to the assessing the vessel again. Again, this can be done in different way, fluoroscopic guidance. If the vessel is calcified like this, you can do a AP and lateral oblique views, and you can puncture the needle at the intended puncture site. A road mapping by doing an injection from the above and then puncturing the same area. However, again, duplex guided access is more suitable for a radiologist or the IR people. What you have to remember is that the position of the foot should be changed if you are planning to do the tibial vessel versus a peroneal vessel. For example, if you want to puncture a dorsalis pedis or an anterior tibial artery, you have to keep your ankle in a plantar flexion way. This will ease you in puncturing the anterior tibial or dorsal pedis. Similarly, if you want to puncture the posterior tibial artery, the ankle should be kept in a eversion and dorsiflexion. And similarly, for the peroneal artery, you should keep your ankle and the leg in the inversion position. Again, for this superficial artery, we use micropuncture needle. Sometimes it is very, very handy to bend your needle tip slightly of the micropuncture needle, because sometimes it becomes difficult to go straight. Once you bend your needle slightly, it will allow you easy passage or easy access of this pedal arteries. Depending upon, again, whether you want to go for a sheath or no sheath, we can decide on that depending upon we want to intervene from above or below. But what is more important to remember that since these are small vessels, you have to adequately heparinize this vessel once you get the access. And we typically use a cocktail mixture in this situation where we give 3000 units of heparin bolus stat. That is followed by 200 microgram of nitroglycerin and maybe diltiazem or verapamil depending upon the situation, injected slowly in a dose of 2.5 milligram over a period of time. So believe me, when you give this kind of mixture, your access will remain secure. It will not go thrombosed, or it will not go into a spasm, and you can complete your procedure with much difficulty, without much difficulty. Moving from the lower extremity access to the upper extremity access, and the indications could be either an obligatory indication because in situation where there is a aortoiliac occlusion and we want to intervene in some visceral vessel or maybe the upper limb vessel. It could be adjunctive in situation where in a complex intervention like a TIVAR or a IVAR, where you are doing intervention from below, but you want some angiography to be done from above. Or it could be preferential in those situations where you want to intervene in the visceral artery again, and when you come from above, it gives more inline flow to the vessels which are more caudally oriented. So for example, if a superior mesenteric artery is oriented more caudally, a upper extremity approach will be more successful or more preferential as compared to the lower extremity approach. If you look at the history of the upper extremity approaches for the vascular access, the initially axillary artery was tried. And you can look at this angiogram picture that typically the axillary artery was punctured at this location outside the rib. However, it has got a lot of disadvantage in terms of hemorrhagic complication, and also because there are a lot of nerve rami which are present on the surface of this axillary artery, which causes a lot of nerve injury, also brachial plexus injury in this patient. So it was not so popular among the IR people. Subsequently to this, a high brachial artery access, which was just immediately distal to this axillary artery, was developed. But again, with the thought that if you can look at this diagram, you can see that in the high brachial artery, the nerves, the ventral surface of the artery is devoid of nerves. So even if you come from the ventral surface of the artery, you will not be causing nerve injury. But again, it was seen that because of this medial brachiofacial compartment, which is typically called as MBFC, even a small amount of hematoma spread rapidly inside it, and then it causes its own complication of nerve injury and so. So what about the lower brachial artery access? That is the access in the region of the antecubital crease. Again, it has got challenges because the vessel is quite superficial here. It's quite mobile with a very lot of little soft tissue support. And also there are frequent variant anatomy in terms of high bifurcation, low bifurcation. And all this create a challenge if you are planning to do a low brachial artery access. But nonetheless, if you really plan to do this, the ideal site to puncture is actually 1 centimeter above the antecubital crease, medial to this biceps tendon, as you can see in this representation. And we can be either, as we did in the pedal artery access, also here you give little amount of local anesthesia first, and once you get the access, then only you infuse total anesthesia to avoid any issues of complications like arteries going into a spasm. But again, the low brachial approach has got this issue of reaching up to popliteal region, and it has certain other drawbacks as well. What about the radial artery access? So it was much underused, I will say, by the intervention radiologist, and it was largely the domain of the cardiac cardiologist. However, this was the first report which was published in JVIR in 2016, which has looked at the feasibility of transradial approach for non-coronary intervention, and it has established the safety and feasibility in this group of patients. Obviously, it will provide you an easier post-procedure hemostasis. It will decrease risk of hemorrhagic complication. You can ambulate the patient immediately after the procedure. You don't have to make the patient lie down supine for 6 to 8 hours. And it's especially useful in obese patient where a femoral access could result in, you may not be able to compress those patients' accesses. This was another article which was published, which looked at the safety and feasibility of transradial artery access for visceral artery interventions in patients with thrombocytopenia. And it has shown that even in patients who had got a higher INR, even in the range of 2 to 2.5, a transradial access is associated with less bleeding complications as opposed to the as opposed to the retrograde femoral access, where we typically want a INR of 1.5 or less than 1.5. So a transradial access offers you intervention in those situations also where the INR is raised as compared to the other accesses. However, again, the same problem, if you want to do interventions in the below the groin region, in the femoral or popliteal territory, you may have limitation in terms of adequate catheter lengths or hardware. How to choose the patient for radial access? It's very, very important that you assess the collateral perfusion of the hand. And how we do is that is by the called as modified Allen test or called as Barbeau test. What you do is that you put your pulse oximeter on the thumb of the intended side of the vascular puncture. Then you compress the radial artery at this point. And once you compress the radial artery, you can have either of these four values or graph in your oximeter. In the type 1, you will see that there is no change in the amplitude of the pulse wave after the compression, and it remains so after 2 minutes. In the type 2 kind of curve, you will see that once you compress the radial artery, this oximetric waveform decreases in amplitude. However, it returns to normal values after 2 minutes. In type 3, you can see that immediately after the compression of the radial artery, this has gone. And there is a comeback after 2 minutes, but that was decreased in amplitude. And in type 4, you can see that it has gone after compression and it has never returned back. So when you see this kind of curve, type 4, you know that this vessel is not adequately collateralized by the ulnar artery, and this is an absolute contraindication for, not an absolute, but I will say a relative contraindication for radial artery access. If you look, other three patterns are okay for going into the radial artery. But what you should remember is that the rule of thumb should be that if you should measure the diameter of the sheath and then compare with the diameter of the diameter of the artery must be greater than the outer diameter of sheath. So if we are intended to use a 5 French sheath, the outer diameter may be 6 French, and you should compare that with the diameter of the artery. But roughly, if the artery is less than 2 millimeter, don't try to puncture the radial artery, because more often it will result in thrombosis or occlusion of the radial artery. The technique is similar as compared to the other vascular territory, but what you have to remember is that you have to puncture 2 centimeters above the radial styloid process, and this is the single most major which has shown that if we puncture the artery at this point, it is associated with least complication. Again, as we have seen in the pedal puncture, cocktail mixture is also administered here to prevent any spasm or related complications of the smaller vessels. So having learned about the various techniques of puncturing these peripheral arteries of the upper and lower extremity, it's important to remember that a sheath removal is again an art. If you will be crude, you will result in a lot of complications. Always ensure that your activated clopping time is less than 180 seconds before the sheath removal. There could be various manners or various ways by which you can remove your sheath, and manual compression is considered as the gold standard. There are mechanical compression devices like the C-clamp and pneumatic inflatable devices, but this can be used in certain situations. But if you are using it in the femoral access hemostasis, never use the devices unintended, because with slight movement of the patient, these devices position can change. So always get it supervised. Vascular closure devices can also be used in many of this situation, especially to reduce the time of hemostasis and to allow earlier mobilization of the patient. There will be certain situations where there is a lot of coagulopathy or there is issues with the platelet count or iron are very high. A closure device may be considered for reducing complication in those situations. I would like to reemphasize, you should always optimize your manual compression, because this is the best you can do. Again, as you have done for when you were trying to introduce the needle, you have assessed for the local anesthesia. Again, assess the need for the local anesthesia to the patient, because when you will be compressing, there will be pain at the site of the puncture. So again, assess. If you require, you can repeat your local anesthesia at the injection site or the compression site. You have to compress both above as well as below the puncture point. First, compress below the puncture point. Let a sprout of blood come out, and then you compress the above. Use the flat of the hand, because if you use the fingers, it can lead to exhaustion of your joints. Ideally, 50 to 20 minutes is adequate, and we roughly follow a formula that for each French, 2 to 3 minutes is adequate. So for a 6 French sheath, nearly 15 to 20 minutes is okay. In the initial 2 to 3 minutes, try to compress with full pressure, and then subsequently you can reduce your pressure over the next period and time. Always look on the BP and the heart rate, because many a time this patient can go on vasovagal while you are compressing. While we are compressing, it's very, very important to check the distal pulses, and it should always be felt. Maybe reduced in volume or amplitude, you should not obliterate the distal pulses, and you can ask your one of the colleague to check the distal pulses while you are compressing at the intended vascular puncture site. But having said this, after this, once you have achieved the hemostasis, you can embolize the limb for next 6 to 8 hours. In the meantime, during the observation, you can always look for hematoma, check for the distal pulses. And our strategy, whenever we intervene in any of this patient, will always do a follow-up Doppler the next day to look for any access site complications. However, despite of the best of the care regarding the access site, complications do occur. And if you look at this slide, among the various complications which are related to an angiographic procedure, the access site complication is actually the most common. And what are the factors which are responsible for this? So this could be roughly divided into patient-related factor or the procedure-related factor. If you look at the patient-related factor, advanced age, as we know, the vessel will be fragile in the advanced age. Obesity, you will not be able to compress the vessel well. You maybe have required to make multiple puncture in obese patient. A female gender is typically prone to vessel going into spasm. Hypertensive patient. So if you are trying to pull out a vascular sheath, always check the pressure prior. And if the systolic pressure is more than 180, never try to remove the sheath in that. Try to control the pressure first and then only remove the sheath. Patient with a CKD, patient with a diabetes, they have a very small, fragile vessel, diffusely calcified. A presence of concomitant lower extremity vascular disease and uncooperative patient, these all add to the factors which could lead to access site complications. If you talk about the procedure-related complications, the technique of puncture, like multiple puncture technique, use of large site, a long time for sheath removal. So I always say the longer the procedure, the higher the chances of getting complication at the access site. If there was some thrombolytic therapy which was done prior to this in the immediate period to the vascular access, it has got a higher chances of complication. And in certain patients who are on higher heparin doses with antiplatelet and antithrombotic adjunctive treatment, they are again at the higher risk of access site complication. And despite if there is something called as bad luck, which you can never avoid. So to summarize or to tabulate the different form of complication, it could be either a hematoma, it could be active hemorrhage, it could be a pseudoaneurysm, it could be AV fistula, thrombosis, neurological complications, or rarely infection because of inadvertent introduction of the infection either from the hardware or from the skin puncture. And we will look at each one by one. So hematoma is typically defined as a swelling around the access site, and usually they are not associated with active bleeding. It's mainly because of inadequate manual compression, and once you do a firm compression over the local site, you will see that the hematoma will regress subsequently. But it's always important to mark a boundary around the swelling or the hematoma which you see around the groin. Because if it is expanding, that will alarm you that there is a maybe active bleeding in the site and needs further investigation in those patients. This is an example of a patient who presented with a hematoma in the right lateral abdominal wall. And the problem in this patient was because there was an inadvertent wire passes into the circumflex iliac artery when the sheath was introduced. And this has resulted in the perforation of the artery and resultant hematoma in this location. So always, whenever you are trying to introduce your guide wire, always introduce this under the fluoroscopy, because if you don't do, you can inadvertently allow your wire to go either into the circumflex iliac or maybe the inferior epigastric artery, and this can perforate and cause complications. What about retroperitoneal bleed? As opposed to the hematoma, groin hematoma, which doesn't represent an active bleed, a retroperitoneal bleed often represents an active bleed. Also, in a hematoma, you will see a typical swelling at the site of the axis, while in the retroperitoneal bleed, the blood will leak slowly, and when they present, you will see a large hematoma in the retroperitoneal compartment, and the patient present often with a pain or maybe change in vital sign, fall in blood pressure, or maybe a decrease in hemoglobin. Most of the time, it is associated with a high puncture above the inguinal ligament, but up to 45% of the patient, the retroperitoneal hematoma was seen to occur despite the puncture in the common femoral artery location below the inguinal ligament. And one of the reasons which is cited is that there is a communication of the femoral sheath with the retroperitoneal compartment in many of these patients, which allow tracking of the blood from the femoral compartment and it goes into the retroperitoneal compartment. And believe me, if this occurs, though this is rare, but many a time it becomes fatal if it doesn't get diagnosed in a earlier time. Usually it happens 2 to 3 hours after the endovascular procedure or after you have removed the sheath. So whenever in the ward patient is lying and when he complains of some flag pain or change in vital sign, don't ignore it. Try to investigate, try to rule out that there is no retroperitoneal hematoma. You can do ultrasound in those situations if the patient is stable. And if the window is not good and you are suspecting some issues, go and do a CT to rule out a retroperitoneal hematoma. Sometimes the patient will not give you any time and will present immediately 2 to 3 hours after the procedure with signs of hypotension or shock. So in those kind of situations, always take the patient back into the lab, take a contralateral access, do the injection for the ipsilateral or contralateral vessels and look for the site of bleed. As in this case, this was the site of the rupture of the vessel, which was causing retroperitoneal hematoma, and immediately a balloon tamponade was done in this patient. Majority of the situation, the balloon tamponade will help you in rescuing the situation. However, even after balloon tamponade, there is persistent leak. You can think of treating this patient in an alternate strategy like use of a covered graft or if there are suitable landing zone. And if no suitable landing zone, a surgical treatment may be considered in those cases. Femoral pseudoaneurysm is often one of the common complications we see at the local access site. And again, the patient and procedure related factors are causes for that. The management strategy is focused around conservative treatment if it is small and asymptomatic, if it is size is lower than 2 to 3 centimeter, or if it is symptomatic or it is enlarging, ultrasound guided compression, ultrasound guided thrombin injection, embolization if there is a track to the pseudoaneurysm. If there is a good landing zone, we can even deploy a stent graft. And if none of these are suitable, a surgical repair may be contemplated in management of this patient. And this is an example of a patient with an access site pseudoaneurysm at a common femoral artery site, which was well managed with an ultrasound guided compression. Another example of a patient where there was an access site pseudoaneurysm, and in this case, it was managed with an ultrasound guided thrombin injection. What is important to remember, whenever you see that there is a pseudoaneurysm at the access site, always rule out AV fistula in those cases because many of these patients will have concomitant AV fistula. And if you inadvertently put thrombin in the sac, it can cause issues related to the venous thrombosis as well as arterial thrombosis. As in, you can see in this case, there was a pseudoaneurysm with the associated fistula. And in this case, this tract was embolized with a coil in this patient, which has taken care of the problem in this patient. AV fistula can occur in isolation as a primary problem, but moreover, majority of the situation, they are small and resolve spontaneously and are mostly asymptomatic. However, if they persist, a image-guided therapy may be considered in many of these situations. This is also one of the common problems if your procedure is prolonged or there is inadequate heparinization, access site thrombosis. So what you can do is that once there is a formation of a thrombus, you can try to thromboaspirate and use some thrombolytic to take care of this kind of problem. To prevent this, there often in time what you can do is you can keep your patient warm and hydrated, minimize manipulation around the vascular access sheath, use hydrophilic devices, use vasodilators, low profile hardwares, and many a time anxiolytic medication is also useful in preventing a spasm and preventing thrombosis of these vessels. So I would say that complications are bound to happen, but if you are forethoughtful about a given issue, if you pay attention to detail, if the patient is deteriorating in the table, on the table, or maybe in the ward, you can anticipate that there is some issue, some complication. Don't put it inside the carpet. Try to investigate, try to come to the problem, what is happening. Try to judge, and if you have a fear, always be fearful. We say that fear from God, fear from these vessels. And if you fear from these vessels, they will help you in making right judgment. You will be mostly right in many of the situation. And what is important is that you should always establish the clear indication of the procedure, and it should not be just a technology or a skill demonstration. So to summarize, I would say that proficiency in various vascular access technique is important for not only providing the therapy, but performing the safe and successful complication of endovascular procedure. Your thoughtfulness, judgment, and choosing right access is important in achieving the desired goal. You should know about the different vascular anatomy, the variations, and shouldn't get surprised when you see a given anatomy at a particular vascular access site. Know your hardware well. That is very, very mandatory. And judicious use of different technique like fluoroscopy, ultrasound roadmap help in easy accomplishment of the task, that is getting the vascular access in majority of the situation. So respect your vessel and the vessel will respect you. Thank you very much for your patience here. And I think we can now open for the questions.
Thank you, Dr. Sanjeev, for discussing these thought-provoking points. I myself learned so many new points, such as taking history of COPD and looking for the vasovagal shock during decompression, and also using cocktail mixtures, which I am really, audience will be very benefited by your discussion. And it is indeed a great effort and well done. And you could answer most of the questions. There are few questions which I would like to, which attendees have posted in the chat box. Why intervention radiologists are not using radial access to treat visceral artery lesions and PAD?
So earlier, what I said is that earlier the experience was limited to intervention radiologists. Intervention radiologists are more common of using large size hardwares for treating the peripheral vessels. But with the advent of the cardiologist, when they started using the radial access, now more and more intervention radiologists are also using radial access, especially for doing the visceral artery intervention. And I would recommend everyone who is planning to do some visceral artery intervention, if you see that the radial artery is adequate size, you can actually plan to do your intervention from the radial artery access, as it has shown to be associated with much lesser complication as compared to the other access site.
Okay, thank you. And next question is, in case of high CFA bifurcation, what is preferred, puncturing ipsilateral SFA over femoral head, or to look for contralateral side, considering contralateral side is of normal bifurcation?
So that's a very important, that's a very good question actually. So if you look at the variant anatomy in patient who had a high CFA bifurcation on the one side, more often you will see that there is a high CFA bifurcation on the other side. But nonetheless, if there is a normal anatomy on the other side and you can alternatively choose that axis, you can go for that. But suppose that both the side you have a high CFA bifurcation. So what you can do is that you can puncture the superficial femoral artery over the femoral head. Never ever try to go above the inguinal ligament in the CFA if it is above the inguinal ligament. Puncture SFA in the vicinity of the femoral head and you will have no problem in those situations.
Okay, sir, what you do if there is a dissection while doing a right femoral puncture?
So mostly, as I shown in one of your slide, that the dissection can occur at various stages of the axis. The dissection can occur while introduction of a wire through this large bore needle. In those situations, the wire will not go further. Look at the fluoroscopy, look at the ultrasound, why the wire is not going. When you will see on ultrasound, you will see that the wire is not intraluminal, but it is going into the subintimal space. So don't try to push the wire, take out the wire, compress the site. You can use the other access site. Most of the time when you are introducing the wire and you find the resistance, you stop your advancing the guide wire. The dissection which happens is generally non-obstructive. However, during the course of the procedure, you can have dissection also related from your sheath. But if you are using, if you try to negotiate your sheath in the tortuous iliac vessels, again, you have to look whether it is a flow limiting obstruction or a non-flow limiting obstruction. If it is a non-flow limiting obstruction, you can maybe slightly try to balloon tamponade it and you can get away with it. But even after balloon tamponade, if you see that it is limiting the flow, then you have no strategy but to stent with a bare metal stent. Normally, when you take a retrograde femoral axis and the dissection which happens doesn't propagate as compared to an antegrade femoral axis, and the dissection occurs, it will propagate more distally. So that is one relief, that if you are creating a dissection in a retrograde femoral axis, there is a more chances that it will not propagate further.
Yes, because directly related to flow of the artery actually.
Yes.
Then how to aspirate thrombus from CFA if patient comes back after a week with CFA thrombosis?
So we know that after a week, CFA thrombosis represent actually a subacute. It's no more an acute stage. You can take a contralateral sheath. You can take a large size, maybe guiding catheter at the region of the CFA, try to aspirate. At a 7-day, there will be less chances of just a simple manual aspiration will not work. You may have to infuse some thrombolytic agent. Once you do infuse thrombolytic agent and then you try to aspirate with a large bore guiding catheter, you will be more often successful in most of the situation.
Any experience with distal radial access and pneumatic inflatable devices in terms of time required for compression?
So that's the usual compression management strategy for the radial artery access. Pneumatic inflatable device generally have to inflate it for 10 to 15 minutes, and then you can ask the patient to get mobile. That's the usual time. That is the standard of care for most of the radial artery access. We are using it for a majority of the patient, pneumatic inflatable device.
Okay. Any guidance on amount of heparin with respect to time for routine vascular procedures, or is it always ACT based?
So yes, that's a good. So you should know the half-life of heparin. It's usually in the range of 60 to 90 minutes. And once you have given a therapeutic dose of heparin at the beginning of the procedure, after a prolapse of 60 to 90 minutes, you can do a ACT. Or if you don't want to do a ACT, or if ACT is not available, you can always accentuate the heparin doses after the half-life. So approximately.
Is ultrasound guided single wall puncture the best option?
I think for the intervention radiologists who are versed with ultrasound, I think ultrasound guided puncture is one of the best technique, because it prevent you from inadvertent puncture of any other vascular territory, and it also gives you a secure and safe placement of needle with a single wall puncture in this vessel. So I would recommend, if ultrasound is available, always use ultrasound.
Okay, Dr. Sanjeev, thank you very much for such a wonderful lecture, as well as the answers which you answered in all the queries. And some remaining questions, they can directly mail or write to us. We'll get the answers from our experts. And I sincerely thank Dr. Sanjeev for this excellent lecture, and extend my gratitude to all the ISVIR executive for starting this wonderful initiative. And I also I thank all the audiences for making time with us, especially during this weekend, and participating with great enthusiasm. And I could see it's almost touch 70 at one time. And I hope this benefit of this today's masterclass and the special points which Dr. Sanjeev highlighted in the most basic topic will pass on to your practice. And our next masterclass will be on hard waves, catheters, guide wires, and guiding catheters by none other than Dr. Matthew Cherian on 28 May 2022. So finally, I would like to conclude master class and hope you all enjoyed our academic initiative. Thank you, Dr. Sanjeev.
Thank you, sir. Thank you very much. Thank you all the participants for your patience here.
Thank you, sir. Thank you, sir.